We are excited to have Dr. Dylan MacKay from Winnipeg, bright and early, present to us on randomized trials of dietary interventions in CKD. Dr. MacKay is a PhD scientist at the University of Manitoba. He's an assistant professor of nutrition and chronic disease in the Department of Food and Human Nutritional Sciences, as well as, I think, cross-appointed to the internal medicine section of endocrinology. He's got a background in He's got a background in human nutritional sciences with training and experience in clinical trials as well as patient-oriented research. And his research is mainly in nutrition as related to diabetes and chronic kidney disease. He's leading a couple of trials looking at dietary interventions in CKD. So welcome, Dylan.
Well, thanks for the invitation. All right. Well, thank you for the invitation and the introduction and the opportunity to talk to a lot of nephrologists about dietary interventions, which is what I love to do. So I'm going to start off just with a territorial acknowledgement. The University of Manitoba is located in Treaty 1. So that's the ancestral territories of the Anishinaabeg, Anishinaabe, Dakota, Iote, Denisula, and Nahuatl nations. It's also the homeland of the Red River Métis. So, I personally acknowledge that the place where I work is in the residence, and my personal residence are in these territories. And, the water that I drink is from Treaty 3, and the power from Manitoba Hydro comes from Treaty 1, 2, 3, 4, and 5 territories. And that, I always try to remember in my own engagement with reconciliation that there are historic but ongoing harms that continue to harm Indigenous people, and so I'm committed in my research capacity at the University of Manitoba and my life in learning more about the richness and diversity of Indigenous cultures to help combat that. And of course, within the populations of the trials that I work with, there is an overrepresentation of Indigenous people in chronic kidney disease and in type 2 diabetes populations in Manitoba, and that's important to think about when we're doing the work that we do. And just to start with a positionality, a little introduction, if people don't know me from what I used to be on Twitter, I'm a white settler. I'm a Canadian-German dual citizen. So my mom moved to Canada from Germany and never gave up her citizenship. I speak German, and I was sent back to Germany as a kid quite a bit. So, and I have 2 invisible disabilities. I live with type 1 diabetes, which is likely why I do dietary intervention research. It was either that or become an endocrinologist was sort of the thoughts that I had. I have 2 kids in Manitoba here. I would say I'm quite progressive. I'm married to a nurse practitioner, and she works in the College of Nursing at the University of Manitoba as well. And I'm originally from Newfoundland, so I moved to Manitoba to do my PhD. And I love the opportunity to work with nephrologists because I really believe that I want to be the dumbest person in the room so I can learn a lot. And I'm really lucky with the collaborators that I work with in Manitoba that I get to learn so much. So just to start with some disclosures, I know I have some honorary speaker fees from Diabetes Canada, Diabetes Update, and Abbott. I have funding from CIHR, Kidney Foundation of Canada. PepsiCo was related to a trial in oats. They own Quaker, and so I've worked with Agriculture Canada and PepsiCo on a trial that's ongoing. The Weston Family Foundation, the Westons fund one of the projects I'm going to talk about, a proof of principle study, and I have a prairie oat grower as well related to oat research, the clinical trial activity. And then just other, as a person with type 1 diabetes, I use an automated insulin delivery system. And so those used, Novo Nordisk products, Insulet products, and Dexcom products to make that kind of thing. And in some of the trials that I'm going to talk about, I do have agreements for in-kind service and products with Save on Foods grocery stores and Food Fair, because working with grocery stores, as you'll see, is sort of how I try to work on delivering some of the dietary interventions to people. So really, I'm one half of a research group. The other half of my team is Dr. Rebecca Mollard, and she's based at the Seven Oaks General Hospital at the University of in Manitoba at the Chronic Disease Innovation Center, and we focus typically on dietary interventions in chronic kidney disease and type 2 diabetes, but we also do any food-based clinical trials and glycemic response testing, and I've done some work in the area of type 2 diabetes remission. But what we're talking about today is clinical trials in nephrology. And this is sort of, I think, my opinion of the entire area of clinical trials in nephrology is there's not enough of them. They're often low quality and there's poor reporting for various reasons, which I'm learning more about as I do more of them. But, uh, it's unfortunate that the guidelines are informed by less clinical trials in CKD. I think that's sort of just how the field has evolved, right? The history of chronic kidney disease research. And I think that's very interesting. But, nephrology trials make up less than 3% of clinical trials, at least in 2010. And there's been improvements, and, the standards of care have evolved, and some of the new pharmacologics have greatly, I don't need to convince the people in this room, have greatly improved chronic kidney disease care. But of those trials in CKD, more than 75%, probably more than 90 are still pharmacological agents. So, lifestyle interventions related to food and exercise and things like that are a very small minority of too few trials. So I think a lot of the dietary recommendations in CKD are not really based on good evidence. At least the higher quality evidence. There's lots of observational. There's lots of clinical informed recommendations, but I think we want guidelines that are informed by trials. But then again, I'm a trialist, so there's a bias there. And so what's been interesting, I guess, from my career is I've been able to connect with some incredible mentors in nephrology, like Dr. Navdeep Tangri, Claudio Regata, Clara Bohm in Manitoba. And there's an incredible nephrology research team there. If anybody's, looking, I'll do a recruitment shout out. They're just fantastic. And we've been trying to answer some questions around dietary interventions in nephrology across different stages. And so I'm going to talk about a couple of those. I may not make it through all of them. I can skip one to get to some questions and stuff. But one of the trials looks at resistant starch. Another one's looking at food versus oral alkali in metabolic acidosis. One that evolved from the metabolic acidosis trial is exploring potassium liberalization. And then finally, we have one looking at protein consumption in kidney failure. The first one I want to talk about is really coming from an idea of the uremic toxins that build up in CKD. And so through discussions, with the nephrology team and with people with lived experience, the uremic toxins often associated with the itching and a lot of the bad symptoms related to late stage kidney disease. And, there's different ideas of ways we can potentially take those down. And there were some agents that have been explored this way, but, many uremic toxins are derived from the gut microbiome, essentially through the metabolism of aromatic amino acids. That's the gut, the bacteria living in the gut, digesting excess amino acids or protein. So, we had this idea, we thought about it, and other people have looked at resistant starch or carbohydrates, resistant starches or carbohydrates that are not digested by human enzymes. But if they get to the microbiome, they're not absorbed. Maybe they could be a food source for those bugs there that may be preferential to the protein metabolism, because uremic toxins are not just bad for the kidneys and the liver and the body and the heart, right? They're actually quite bad for the other bacteria in the gut microbiome. So a cleaner fuel might lead to less of those. And so we had a question of, can resistant starch consumption reduce uremic toxins? And we put in a proof of principle grant that was funded looking at that. And the idea for this is there's a raw potato starch, which is a type of starch from Manitoba that is made there. It just so happened that it's quite pure. It's quite a low. You get a lot of resistant starch for the dose of powder that's used, and we have been running a randomized 2-period crossover trial looking at this 15 grams of this resistant starch 2 times a day versus cornstarch. And as the proof of principle, we're essentially seeing if we can reduce uremic blood toxins as the primary outcome, with some secondary outcomes related to quality of life, and as well as change in gut microbiome, because that's what the Weston Foundation was funding. This trial was funded in late 2019, and we were ready to go early 2020. We ended up starting in September 2022. The pandemic just was, it's not a great time to start your career in clinical trials unless you were, an ID or vaccine researcher. We are ending the recruitment for this trial at the end of this month, sort of just, we wanted to reach 30 in the crossover. We ended up enrolling, 50, 47, but we, had higher than expected dropouts. We'll likely finish with 25 in the crossover. I'm very excited to look at the results for that. I think it's still going to give us a very interesting question about whether it influences the uric toxin production or not. They're pretty easy outcome to measure well, and in the crossover design 25, I think we'll still have some interesting data from that one. So that's one of the ones that'll be finishing first. None of the trials I'm talking about have data that are finished because I only started in 2019 and I couldn't do trials for almost a year and a half. We couldn't start them for a year and a half because of the pandemic. But the next project that was really inspired by discussions with patients that were being seen at Seven Oaks Hospital was around metabolic acidosis. And Dr. Tangri was very interested in dietary. He's always very interested in treatments of metabolic acidosis. So, there was the Tricida trial that he was a part of, but there's also at the same time dietary interventions. And, metabolic acidosis is reasonably common. I would estimate there's about 300,000 Canadians that are have this, and it is not a great condition. Accelerated insulin resistance, lean body mass reductions are associated with it, and of course a strong increase in the progression of chronic kidney disease decline, progression to kidney failure, and an increased risk of cardiovascular disease with metabolic acidosis. So treatments are still, I think, that's an area where the treatments could be much better because the current oral alkali treatments that still when I first made this trial, it was more common. Now the guidelines have shifted and people are not using it until much lower bicarb levels. But the big bicarb study out of the UK found that even at pennies a pill, it was unlikely to be cost effective. And data from Manitoba shows, that people stopped filling the prescriptions. They stopped taking it, 60% of them or more by 1 year. So it's an area where I think we still need better treatment in nephrology. And so we just recently, this is under review, did a systematic review and meta-analysis of randomized controlled trials looking at dietary interventions for metabolic acidosis. And there were 6 trials that met our criteria, and that we found that obviously the dietary interventions were relatively safe. And there was some superiority of plant-based interventions as treatments. And basically, we looked at these dietary interventions. Quite a few of them came from Italy. Some were from the United States, but they were reasonably effective in treating the acid-base balance, serum bicarbonate. Those first 2 were from the same group in Italy, and that effect size almost too big in my mind. I'm not sure what's going on there, but there were similar effects seen, at least in the plant-based ones, not just in serum bicarbonate improvements, but improvements in eGFR, which I think is the outcome we're really interested, not necessarily the bicarbonate. But if we combine the groups that looked at dietary interventions that were not just vegetarian or providing fruits and vegetables, but looked at reducing protein as well, we didn't see the reduction, the effect on eGFR. We only saw that in the vegetarian or providing fruits and vegetables. And so there's a theory, among myself and some other researchers that low protein diets may not be ideal with this population, and we have other research in that area. But this one sort of definitely reinforced, at least this Goraya study, which is a 5-year outcome study from the US, that providing fruits and vegetables might be an interesting treatment for metabolic acidosis. And so how do you calculate the dietary impact of fruits and vegetables on acid-base balance? There's a PRAL equation. And basically you can have foods that have negative PRAL values, which means they're base producing and they contribute dietary equivalents of bicarbonate. And a healthy kidney, eliminates acid every day, but the most daily acid load comes from the diet. This PRAL equation is basically based calculated from the macronutrients and micronutrients. So it's your protein plus your phosphorus minus potassium and magnesium and calcium, because those are the ions that are bringing bicarbonate equivalents. And this is actually just a photo representative of what a negative 30 milliequivalent of fruits and vegetables would look like in a day. And this is actually what we're using as a treatment, essentially things like this, collections of fruits and vegetables. The Garaya trial was sort of one of this group out of Houston, working with David Wesson. They were some of the first people to publish on this, showing that bicarbonate and fruits and vegetables were similar in their effect on sodium bicarbonate over 5 years versus the usual care that didn't have any treatment for the metabolic acidosis, and that they both improved, reduced EGFR decline relative to the usual care, but there's actually a slightly better outcomes in the fruit and vegetables in terms of EGFR, I think. Not statistically significant in this group, but there were improvements in blood pressure, which were really nice to see in the fruits and vegetables relative to the bicarbonate. Also, this bicarbonate group was really high in terms of they kept taking the medication for 5 years. So I'm not sure what they were doing in this trial, but it doesn't reflect what we see in Canada for the most part. So if you can take the bicarbonate, it might work, but one of the big problems is people don't seem to take it. So one of the questions about this is, of course, could it work in Canada, right? Inner city Houston is very different from Canada, different healthcare systems, different patient populations, right? This patient population in Houston, they picked the healthiest, I think, of the chronic kidney disease patients. So no diabetes, no cardiovascular disease, no hyperkalemia, any of those things. So very different from what we see in clinics in Canada. I think, less than 80% of the individuals that you would see in your clinic would meet the criteria or have this population. Plus the healthcare system and access and all these other things. This food was delivered through inner city Black churches as an interesting mechanism to deliver that, but it was sort of an African American hypertensive chronic kidney disease population, and so we wanted to know, could we do something similar in Canada? And we've been funded to do a feasibility trial, dual center at Seven Oaks Hospital, as well as the Queen Elizabeth in Halifax with Dr. Karthik Tenencourt, who is just fantastic to work with. And we wanted to try to expand the criteria so that we were sort of reflective of the people who come in with metabolic acidosis in Canada. The primary outcomes are all feasibility related, which I already know we're probably not going to hit some of those. We're going to have to reevaluate. That's one of the big learnings we've had right now. But we also had some other outcomes, including we wanted to look at quality of life, clinical chemistry, dietary intakes, 5 repetition chair stand, and other outcomes to help inform a future trial. And this is just some of this is an ongoing trial, and this is just some of the dietary recommendation booklets we have, right? So people are, when they're enrolled in these trials, they start getting deliveries of fruits and vegetables on a weekly basis. And an interesting finding from Houston is when they started the interventions and they were only giving enough fruits and vegetables for that one participant in a household, nothing worked. And then they did some qualitative follow-up, and they said, yeah, well, obviously I share the fruits and vegetables with my entire family, right? A grandparent's not going to be eating the tomatoes and the strawberries, and then have their grandchild or their son and daughter not take part. And the intervention started to work when they gave enough for that dose they were targeting for the entire family. So we're immediately learning from that. And so we deliver enough fruits and vegetables to reach that milliequivalent dose for every family member, or up to 4 of the family members, because we've been seeing it, and they're not using all of it if we send too much fruits and vegetables. We try to titrate that to what's being consumed. So as I said, we kind of created a point exchange system. So 30 to 40 points is our starting dose, which is equivalent to -30 to -40 milliequivalents of fruits and vegetables. And the nice thing about acid-base balance in this thing is we're not making any recommendations around their other intakes, right? We're not telling them to eat less protein or anything like that. If you add base, then you are, then neutralizing acid. At least that's what we're hoping. And so, a daily starting dose. This is, 1 medium apple, half a cup of tomato juice, 100 grams of carrots, and 100 grams of celery. And we're doing lots of qualitative interviews around this. We want to see how we can maybe improve the intervention. If there are issues with preparation and cooking and things like that, maybe we just eventually switch to a ready to eat. And there's lots of ways to do ready to eat packaging where this could be improved that we're looking at. And the package includes these tables that just basically give you a gram dose for 20 points. So these are how many grams you have to weigh up for a -20, -10, -5. We have visits with registered dietitians that explain this. We give people the groceries, but we also send them food scales and measuring cups, and we do training sessions on how to weigh the dose and how to incorporate it into different meals. So we have different examples, and we talk about how to add this to the diet. And try to reach that dose of fruits and vegetables every day. And yeah, we're trialing this now, and we're really excited about it. We've started at both sites. We started in December in 2023 for this one, and we've got 3 people enrolled in Winnipeg and 5 in Halifax. It's ongoing. I wish it had started a year before or 2 years ago, or we already had results. But what I'm learning is that the pandemic was hard to do trials in, and it created new regulatory processes in Manitoba, which have delayed us. And the other thing is, I'm not sure if there's been a shift after the pandemic, but recruiting has been challenging, right? We've reviewed over 800 records to approach 37, and of those, we've had 36 that were outside of our delivery area because we're stuck to Winnipeg, but our population comes from outside of it as well. We're working with Save On Foods and their delivery region in Winnipeg, which is quite good, but outside of the city, we don't really have that ability. We've got lots of people who are eligible that are declining to participate, even though we're providing, the potential to provide either their medication covered or free fruits and vegetables for an entire year. And we've had some issues as well, where nephrologists didn't want these people to be potentially randomized to bicarbonate, which used to be the standard, but then recently changed. And so we have those kind of discussions ongoing where it's a chance that we're going to try what used to be up until very recently the treatment. Despite this, what we've really learned is that we need more sites. So we've been working on a large multi-center study, trying to get it funded. Came very close a couple times so far, but we've lined up 14 sites across Canada from Cape Breton to Vancouver Island. Hopefully this is the last time, we'll find out in July, but we're looking at a larger study, upwards of 224 participants over 3 years, where we want to actually look at EGFR decline rather than serum bicarbonate change. That's hopefully the future of this project. But as we were trying to get this project funded, and further, we continually get this feedback from reviewers about potassium, right? Like, what about all the potassium in these fruits and vegetables? Now, I will say that most of the review panels don't have nephrologists on it, so I'm begging you all to, volunteer for the RC1 and the ClinC and all those panels to provide a little nephrology. We've got lots of people that are saying, "Oh, well, you can't feed potassium in chronic kidney disease," right? And this is the slide I wish I could just present to all of them about where the potassium is. And I think there was just a trial funded with a colleague of mine in Alberta, Dr. Carolyn Richard, who's really going to look at potassium metabolism very closely and interestingly. But unfortunately, I wish that had been done 10 years ago. But we get this feedback every time. Like, what about the hyperkalemia? How are you worried about this? And so I'll go to the clinical colleagues, and there'll be a split, right? Like 4 of them, like, I'm not so worried, and one of them be like, I'm definitely worried about this. And it's really interesting, this idea about potassium, because most of it should be intracellular, right? And the type of potassium in the diet, I think, is really important. And we're like a year, maybe 2 or 3 years away from continuous potassium monitoring. And that's really going to allow us I'm excited about that because I wear a CGM. It's amazing for blood sugar, but CKM will be very good too. I think it'll be very interesting for the field of nephrology. But hyperkalemia obviously is an issue in nephrology, but do we make it worse with high potassium diets? or could we be actually making it better? Because, one of the reasons why it shifts extracellularly is when you have metabolic acidosis, right? So the type of potassium in the diet, the things that are fed with it, I think are really important. Not just the total amount of potassium, but there seems to be related to the amount of phosphate in a food seems to relate to potassium as well. And so there's lots of future research areas in this that I'm going to wait until we have CKM to do them in, but I'm really interested in following up on this. So, there is a potential hypothesis that if you feed higher potassium fruits and vegetables to individuals, serum potassium might go down, especially in metabolic acidosis. But the reviewers didn't necessarily agree on that. And at the time when I put in the proposal for this, and this was in 2020, we were getting lots of feedback on dietary potassium. And I looked at the trials. I found like one controlled feeding trial that was a full formula feeding in end stage, in dialysis patients, where they showed that feeding 1360 milligrams per day versus 11 in an inpatient formula feeding led to a 0.2 milliequivalent per liter lower serum potassium. And that was the only trial I could find that was backing up this potassium restriction. And it wasn't even in the right population, and it was in a formula feed, so it was likely elemental potassium. At least that was 2020, 2021. Since then, the Appel group has published a randomized trial looking at lower versus higher potassium in a full feeding. This is probably a better version of a trial that I have going now, but it was funded, and we'll see what our population is slightly different. But they looked at lower potassium versus higher potassium diets here. So 1600 milligram versus 39, and most of that potassium is coming from fruits and vegetables. And so they did a randomized crossover where they ended up finishing 25 individuals, and they had interesting trial, full feeding, really, really nice to look at. Their population was 69% Black American with 25% diabetes, 93% hypertension, and the EGFRs were 54, so our population is looking at much lower, and we're actually targeting a different population. But they showed that serum potassium at baseline was 4.5, and then the lower K was 4.2, and the higher K was 4.4. So they did show a difference between the two feedings of, again, 0.2, which is the same as that full feeding trial, and they showed a shift in the serum potassium levels, from the high and low baseline. And I think this is kind of interesting to see crossover trials and dietary interventions. You can have these changes in serum, and you can see that. And I would guess the magnitude is around 0.2. And then if you look at the amount of hyperkalemia, they had 2 individuals with hyperkalemia on the high potassium, and 2 individuals with hyperkalemia on the low potassium. So providing fruits and vegetables, or restricting fruits and vegetables when we're telling people that have hyperkalemia. We've done some focus groups and interviews with about dietary behavior and dietary recommendations in chronic kidney disease. And it's really important to those people, but they talk about how confusing it is, right? And how the levels change as their diseases progress, right? First, they're likely often on diabetes recommendations, eat lots of fruits and vegetables, and then it changes as they progress, and they find it very confusing. And then it changes again as they move on to dialysis. And I think that's an area where there's lots of potential to do trials and also intervene. This is like 2 against 2. It's pretty much the same. There's just there was slightly more. The odds ratio was higher for the hyperkalemia in the high group. What we had funded before this trial was published, and we're running it right now, but from the Kidney Foundation, is a liberalized dietary intervention versus standard, and we are trying to get people to eat about 3,500 milligrams of potassium versus under 2,000. And we're doing that by delivering people fruits and vegetables again. Different fruits and vegetables from the metabolic acidosis, because this one's based purely on the dose of potassium in them. So we're going to try to tell them to eat from the baskets, that are greater than 250 milligrams per 100 gram serving versus lower than 200. And so this is an open label randomized controlled trial. We're targeting 30 participants, 20 at Seven Oaks Hospital and 10 at the Health Sciences here in Winnipeg. There's consultation with registered dietitians. We basically have a run-in period on high potassium at the beginning, sort of as a safety, which almost gets us the answer to the trial right away. And then we do a randomized, a randomization to one dietary period for 6 weeks with a washout, and then the other. One of the dietary periods being we deliver high potassium fruits and vegetables, and the other we deliver low. And we're trying to recruit people to this, and some people are like, oh no, you can't send me bananas, or we're trying, we've got we've adapted this with lots of safety measures, that are probably equivalent or more intensive than when we do pharmacological agents that we know impact potassium. But the idea that what you eat will immediately change your serum potassium is really sort of ingrained in the patient populations as well as the providers, despite some trial evidence suggests it's likely not as significant. And I think that's normal when people come in with hyperkalemia. You're like, well, what did you do? And then we think about what they ate, and then we say, oh, well, that's high potassium. That's what was the. We love to have explanations for things, but unless we trial them, they can often be, just finding the answers that may not necessarily be right. So we're working hard on trying to recruit this one. We've have 3 people enrolled. And that have all made it through the high potassium first week challenge, and so we're interested to see how this one continues. We only started in January for this trial. And then the last trial that I want to talk about, sort of, it comes from some of this focus group work that we've been doing, and this focus group work was done even before some of the other trials. So the idea around the metabolic acidosis came from this mixed methods work from the CanFit study, which is a sort of a frailty and CKD cohort that Dr. Tangri started. And we interviewed individuals around their diets, and we compared it to some of their outcomes over time. And the main findings were that despite many people reporting lifestyle changes and being told to adapt their diets to the condition as they progressed, we had lots of suboptimal nutrition, especially in terms of energy, and protein, energy, and fiber, as well as, the potassium was higher than recommended. That we may in certain cases, the sodium was definitely higher than recommended, and the phosphorus intake was higher than recommended across all the groups we looked at. Right, and so are there ways we can intervene on those? Sodium reduction can be done, but lots of sodium reduction at the population level is replacing it with potassium. Is that good or bad, right? And that's an interesting thing that as I said, my colleague Dr. Richard at the U of A is going to be looking at, because as we've been reducing sodium, we've been using a lot more potassium. Right. And so the labels may not be updated, and the sources of elemental potassium have been changing over the last 10 years in foods and beverages and diet hydration drinks and things like that. And in dialysis populations, very few were meeting their protein intake recommendations. And so we were thinking about, what about dietary supplementation in dialysis? I'm interested in the idea of also using dialysis time as a time to supplement, or immediately afterwards. That's sort of the agreement that we came to, because there are some thoughts around supplementing during dialysis, and I'd love to have feedback on these ideas. But our research shows that 20 to 70% of individuals on dialysis likely have protein energy or protein malnutrition there. Energy malnutrition in the dialysis, and some protein malnutrition, probably 5 to 10% of the individuals that we're seeing. And there's already dietary protein supplementation that occurs in the hemodialysis populations in Manitoba. Most of those are things like Ensure Plus, Novosource Renal, those types of they're liquid based, high protein, high energy, or high protein drinks, multiple flavors. I've tried them all. I don't love them. The Ensure Plus is okay, I guess, but I think when you're looking at barriers to protein supplementation, One of them is obviously not all of the products, if they're not adapted for renal, are going to have lower phosphorus, sodium, potassium, and sugar. And so, lots of the people on dialysis also have diabetes. So those are all considerations. The fluid restriction, obviously, these are liquids, so that can be an issue. If it's like in a bar form and things like that, because of the type of population, there's swallowing and chewing issues there. Lack of appetite and nausea obviously are a big issue in this population as well. So the volume to consume is important. And honestly, there's limited products on the market, right? There's like 3 or 4 brands of the same thing with kind of similar flavors. And there's been some improvements in that, but also then the accessibility and cost. These are just feedback we've gotten from people, and the products didn't taste very good. So we were thinking about potential things to add to this, or a variety to this. And we actually thought like maybe a ready to eat high protein custard or pudding or yogurt or something like that would be slightly different, right? It's denser, not as much liquid. You can put lots of protein in it. It's just to change it up a little bit from the normal stuff out there. And we didn't really see any proteins or custards designed for these individuals on the marketplace. And we started developing one. Seven Oaks, the Center for Disease Innovation, CDIC at Seven Oaks Hospital, started developing this with myself and the Food Development Center in Manitoba. And we had to come up with a starting ingredient, and we picked egg whites. The reason why I picked egg whites was essentially egg whites already have low phosphorus, sodium, and potassium, right? The phosphorus is all in the yolk for the most part. And and it is animal based, which is, can be an issue for some populations. And there's thought about that, the animal versus vegetable source protein. And that's something we might explore. But for now, it's very highly digestible. So it's easy to digest for the most part as well. There's allergy issues, but every protein source will have those. But for the most part, it's highly digestible. It's a really high quality protein source. So you can reduce the dose. You get, the biggest return. Some of the other protein sources, especially some of the vegetable ones, are not necessarily complete, or you have to blend to get the same level of completeness, and then you have issues with digestibility unless you go with really purified. And so egg whites were very close to what we were looking for from the start. And we worked to develop a way of concentrating them and putting them into a pudding. And they just sort of took this idea and worked with it. And they came up with a product that's quite high in protein, low in phosphorus, sodium, and potassium. They even found ways to reduce what was there naturally in the egg whites themselves. And also low in sugar. So they used an artificial sweetener that to help reduce that. And so the cups, which are around the size of a yogurt cup, have 180 calories and 21 grams of protein. And I remember the first time I taste tested them, I couldn't believe how like I wanted to be able to buy them myself, before I go to the gym kind of thing. And it's sort of an idea where we're going to take this into other populations as well. But right now we have a project that's just starting. We really like our acronyms to be good, and so this is a high protein egg white. So in kidney failure, so HyperKF. Dr. Tangri is the principal investigator of this one. He's the co-principal investigator on a lot of my trials. Because I couldn't be a qualified investigator anyway. I don't have an MD, so he is the MD to all of my research projects. And this one, we also, since we were using egg, after we had the idea, we approached egg farmers and the biggest egg company, and we said, hey, like this is a potential product we want to develop. So they were interested, and they're funding. We're funding this research program right now. And so it'll be an open-labeled, randomized, parallel feasibility trial at Seven Oaks Hospital and Health Sciences. We're looking for 54 individuals, and the treatment period is going to be 12 weeks. We're going to look at mostly feasibility outcomes for a larger trial, and if people will adhere to the product intervention, consumption of it, recruitment, and things like that. Secondary outcomes going to be albumin, as well as some tertiary objectives related to chemistry and frailty, to set up future trials or to just set up some early material around this product. The idea of protein supplementation is not novel in chronic kidney disease, so this is just to come up with an option for people to select from. That's not a a chocolate or strawberry shake kind of thing. Um, and it's just going to be a randomized parallel arm where you get either the egg white foods or the Ensure Plus or the Nova Source Renal. I'm not exactly sure which one we're using as a control product, but we want to compare them head to head. And right now we have developed this egg product. It's really great. At least I did, but thought it was really, really good. But we're doing sensory evaluations in individuals on dialysis right now. So those are ongoing to see if it's also acceptable in that population that we're looking at. And we have the trials approved and contract. So we're hoping to start recruitment after the summer period in Winnipeg right now. So I wanted to have lots of chance to get feedback and discussions and new ideas on dietary interventions. So I want to have lots of time for Q&A afterwards. But the learnings from these trials, and these are just 4 that I've started or working on over the last 2 years. So I mean, I don't count the pandemic time, and thankfully CIHR and my university doesn't either. But it was it was impossible to do the trials during that time. Is that almost all of the recruitment rates that the nephrologist suggested would be possible to me. I'm now generally cutting them in half or a quarter. So it's a challenge. And I first I started talking about how it's hard to do. There's not enough trials in nephrology, and I've really been learning it's very hard to do those. Right, you need lots of sites. I think the larger pharmacological interventions, they can have thousands and thousands of sites. They've got lots of money for it. For investigator-initiated nutrition or dietary interventions, you don't necessarily have the same depth of pockets for those types of interventions. And I'm really big into the idea of creating networks of renal units that can participate in trials, or like platforms for dietary interventions, because of that recruitment barriers. And even when you identify people who are interested, this is such a high burden disease. It is a terrible condition. I don't need to explain that to any of you, but we work with people with lived experience, and unfortunately through the metabolic acidosis trial, we're now recruiting new people with lived experience, because we've had 4 people with lived experience and they're no longer with us through the process, right? And it's tough. And we'd like to do more high quality trials, because those people are the ones that are helping push and inform these trials, and we want to do them. So it's a challenge to do trials in dietary interventions, but I think that's even more reason to do them, because I think the evidence from them can improve people's quality of life. And I want to finish just sort of, that food is a human right. It's critical for health, and I don't think I need to explain to any of you that barriers to food often correlate with the populations that are overrepresented in your clinics. And I think I want to remind everyone that we have enough food in Canada and all around the world to avoid that. So I think that unequal access and restricted access to foods are set up by systems that have those outcomes for a reason, and they're not necessary. So when you see them, don't accept that they're there because they have to be. I know how much food we make in Canada, from the fields through the logistics. I've been in fruit and vegetable warehouses on farms. I've met with people all across the supply chain around some of these larger trials, because I want to do the health economic evaluations of these types of food delivery. And that's a big component I didn't talk about in our planned metabolic acidosis study. But we think we can give these people fruits and vegetables for probably about $3,000 to $4,000 per year. That's for their entire family. So we know there's health benefits for their children and other members of the family from that. But directly, if we can show that it's equivalent to sodium bicarbonate or better, the Tricida trials and the evaluation, those medications were likely going to come in at 10 to 15,000 per patient per year, right? Because dialysis is very expensive, and if you can delay that, you can save a lot of money. But when I go to a reviewing panel and say, I'm going to give them free fruits and vegetables for the rest of their life, people say, well, that's just too expensive. It's impossible. That's, feedback we've got. Like, this is just not feasible. It's a pipe dream. And I'm like, well, it's a third of the cost of a $15,000 per year drug, and it's much, much more affordable than dialysis. So those types of things, I think we should think about when we don't see food access and is a human right, and the reasons why northern populations, there are systems in place that extract wealth from them through access to food that are a really big problem. And I think there's some incredible work around providing food. Dr. Andrew Buzieri in Toronto started with food. Now he's going to housing and food. But in Canada's healthcare model, those types of things could be cost effective because of how expensive certain conditions are. So I really thank you for the opportunity. As I said, I'm only one half of a huge, one half of two researchers for our group. So everything that I talked about is also work with Dr. Rebecca Mollard. She's there right next to Dr. Tangri in that photo. That's the ring that hangs at the Chronic Disease Innovation Center at Seven Oaks. It's a beautiful facility. If you haven't visited there, get a chance to come, give a talk in Winnipeg and visit. Fantastic researchers there. Yeah, my team from all over Canada, Dr. Leah Cahill is one of the main registered dietitians in Halifax, PhD researcher that I work with. Dr. Karthik Taninkor and Dr. Tangri are just both huge mentors of mine that I, really appreciate all the help. Dr. Collister at the University of Alberta, he was at Winnipeg until recently, and some of his work in uremic toxins, and he's doing some of the cannabis stuff there. As well as my postdocs, people with lived experience that I've worked with, and that I'm hoping I can find more people to work with in the future. And so yeah, it's research is a team sport, so I can't really take any individual credit for this. And so if you have questions, I have questions. Like in a room full of nephrologists, I'm always asking questions. But if there's any discussions, ideas, thoughts, I would love to have that, because I'd like to try to figure out why I'm making a mistake before I make it, if I can. So any feedback would definitely be appreciated.
Absolutely. Thanks, Dr. MacKay, Dylan, for that wonderful presentation and great body of research going on. I really wish you success for all these trials. But stepping back again, and I think you did. So if people have questions, please raise your hand and unmute yourself. I'm just going to ask one question from the chat before I go to the conference room. So Tamara asked about why were people unwilling to participate in the trials, and I think you alluded to that, but is it especially I guess for the metabolic acidosis, the base trial, as well as for the potassium trial, is it because of the potassium content? Why are patients reluctant?
We track it right now, and it was in really small print there, but I can let me look up zoom in on some of those. A lot, we have people. Sorry, that's the wrong trial. We have people who are afraid of the potassium. Honestly, some people are just worried about hyperkalemia a lot, and so they don't want to. As I said, we've had some nephrologists, or we had at least one nephrologist who was like, at 22 bicarb, they didn't want the chance of their participant to be randomized to bicarbonate therapy, which is definitely a change there. In the metabolic acidosis trial, we have tighter criteria for serum potassium. So some of those individuals serum potassium is out of the range. People outside of the delivery zone has been unfortunately quite high. And the people who have declined simply because the burden of being in the trial, once we explain to them that they'll get grocery deliveries for a year with quarterly research visits, it's just an extra burden, and we're trying to get that across. And I think some of that is just building more of a research culture through the staff and the units, and hope that gets created in the patient populations as well. Because like I said, we've been doing these trials at Seven Oaks only since the last year or so. So as more people have positive experiences and that trickles through, we're hoping that will increase, and that to a point where people are interested in getting into trials. But I think that's actually a culture thing that we need to highlight. We need to talk about the research more. We want to have more research, display boards in the units, and so staff and everybody around it sees the potential there. But a lot of the times it's just one more thing that people are worried about on top of their condition that they don't think they have the capacity for. So it's been more than we expected. We thought that, hey, free fruits and vegetables might be a bigger draw, but it's not necessarily the case.
Yeah, Todd saying that in the chat as well, saying, who would turn down free food? But I guess some people do.
Yeah, that's unexpected. So yeah.
The conference room, please.
Yes. Thanks. Can you talk a little bit about the choice, like the difference between providing dietary counseling and providing the food baskets? You talked about sort of, access to fruit and vegetables, and that seems to be maybe one good reason to actually provide the basket instead of the dietary counseling. But are there other reasons that you decided to go with the fruit baskets, the food baskets instead?
Yeah, I mean, so I presented that mixed message paper near the end, but that actually predated and led to a lot of that. One of the first grant I ever received was an engagement grant through a SPORE to go interview individuals with chronic kidney disease across a range of the progression of it, and the feedback being that and having chronic illness myself, it's like time is quality of life, right? And access is time. And so when we've worked with groups and we've talked to, say, the Can Solve Patient Circle or the Diabetes Action Patient Circle, they love the idea of delivering, right? Because that's food work, and that's a whole other project that I wish I should have talked about, and I will. But the work around household food work, which we know eating at the home is healthy, that's a lot of work. And the planning and the grocery shopping and the preparation, those are all things that if we can take those away by directly delivering. And the other thing about the directly delivering is while we provide a range of fruits and vegetables, we still have a list that we select from to maximize the bicarbonate, right? And that changes, and we interview people and we ask them to select what they like and what they don't like from the list, and try to adapt those boxes on a weekly basis, and also provide some seasonal change. But it's really about that barrier, and then it's not just knowledge, but it can be cost.
And let them all download, and then I choose like what I want to do.
Cost and access. And so if it doesn't work because they don't know, they can't prepare it to eat, then the next step we're going to do ready to eat things, to try and overcome those, because the ability is another one of those things in some of the populations, right? So it's burnout of caregivers. If I have to go make a special meal, or I have to shop for a special meal, it's going to be tough. But if we just give them the food, then that's the thought. Just give the people the food is sort of the mantra of our interventions.
Thank you. Jan, I have more questions about that issue, but I'll let Jan ask first.
I think hi, thank you for the talk. It's a very interesting area of research. I think you started to answer my question, which was around preferences. So I think there's people in general have very strong preferences about their fruit and vegetable intake, and vegetables in particular can be a particularly a time-consuming food preparation, peeling, chopping, cooking, and so on. It can be tougher. But I guess related to that, I was wondering, do you guys ever have conversations about the medicalization of food? Because food, in a way, is supposed to be one of our great pleasures for many of us, and we are constantly saying, no, you can't have that. Now we're saying you must have that. And it seems like that is a real big emotional burden. Yeah.
So there's lots of, this is one of my pet areas, actually. And I wrote an op-ed on food is not medicine. That went pretty wide and got me in trouble in the Canadian Nutrition Society. Many people wanted to wrote a letter that they wanted to publicly censor me on it. But it's a huge thing, right? So I have type 1 diabetes. I think about food all the time. I wouldn't say I have a normal eating pattern, because having type 1 sort of pathologizes eating, but you try to adapt to that. And so we probably have about 25 different vegetables and more than that in the fruit, and we ask people to select the ones that at least they like the best, and we try to provide variety, and we give options of putting it in. But I wrote an op-ed, and I still agree with a lot of that there, because I think food as medicine as a concept is quite bad, but it's how it's used. And so I think the idea of providing free fruits and vegetables, or providing food to people free and reducing barriers, is likely a good intervention. And it's good for healthcare. But the concept of that food as medicine has those potential negative drawbacks, and that's a discussion that we have ongoing all the time. And so that's why we try to maximize choice for individuals as much as possible, highlight preference, adapt to the types of diets, the cultural backgrounds in our education, meeting them where they are, and then trying to find a way in say the metabolic acidosis trial to try to enhance the bicarbonates they're eating through the foods that they and give them those ones. And in the potassium one, it's just sort of proof. We want to see how much we can actually change it. That's sort of a safety one. But the big treatment potentially changing one, it would be the metabolic acidosis trial. And that's one we need to try and keep that in mind, right? That we still maximize that choice and we don't turn eating into a burden. But in many cases, we're already hearing that from people with chronic kidney disease. The fact that they can't have potato, or they think they can't have potatoes, or that, all I eat is white toast because I know it's safe and I can and I can keep it down. And so the idea of a low potassium, low phosphate, low protein diet, that is tough. And when you talk to people about their diet and they tell you about that, that's already very medicalized. And so the liberalizing of some of that is where we're hoping to go with the potassium, and then providing the fruits and vegetables for more variety and cost savings. It's where we're leaning. We talk about that all the time. It's a great question, Jen.
Yeah, I work in our CKD clinic, and people have a real focus on food. Like it is one of the things they can control anyway. So I think it'll end up being a huge area. Thank you.
Yeah.
Thank you. I put up the link to to your op-ed. I was just saying it went to HuffPost and Stat News as well. But let's take one question from the conference room. We have only 3 minutes left.
Hi, thank you. That was really great presentation. A question about your trial with the fruits and vegetables. How much of a concern, and is there a way that you track what the control group, or let's say the bicarbonate group, does? Because naturally, for these dietary trials, if someone is told that, this is a trial on fruits and vegetables, but you're not getting the fruits and vegetables, you're going to end up taking more fruits and vegetables.
Great question. Yeah,
exactly. How do you kind of account for that? Or is there just no way? And, is that a concern for you guys that maybe anything you'll find is just being, brought down back to the null because of what the control group's doing?
Have you been reviewing my CIHR grant? So it is obviously this is one of the things that comes up, right? Like, oh, well, how are your control? And so the cheeky response is I don't care necessarily, because if bicarbonate it was and is the standard people are treating with sometimes or not anymore, it's shifting, right, with the guidelines for metabolic acidosis. And if that's not working or people are stopping it, then if we work very hard on making sure that those individuals take the bicarbonate, but that's not reflective of what's actually happening, then you end up with control or an intervention that's working better than it does in the real world. And if we have contamination by people eating more fruits and vegetables, our intervention, at least as I see it, it's not just eat more fruits and vegetables, because I think making dietary recommendations like that never work. And it's one of the biggest issues I have with nutrition. Like if it's just recommendation based, if you look at certain people can do those things, and those people that can make those changes to their lives are already likely not the ones that are represented very often in your clinics, right? So you might as well go tell people to fly. And so the intervention is not just the telling them, the education, but it's the providing, right? So those individuals who are in the control, they have to go and do that food work themselves to make that intervention happen. And we're trying in our intervention to remove that, right? That planning, that thinking, which fruits and vegetables am I supposed to buy again? How much am I supposed to, do I have a guide to how much to eat? Is it being delivered to my door on a weekly basis? That's the intervention right there. It's the delivery and the food and the education. So the knowledge of eating fruits and vegetables to impact metabolic acidosis is already out there. You can Google it. There are websites. There are patient-facing documents around PROL, but there are still lots of people who have metabolic acidosis. So I'm not that worried in terms of the control. And we know from the bicarb study and things like that, the bicarb's not effective. Maybe it's because people are eating more fruits and vegetables, but I would say in Canada right now, people are not increasing their fruits and vegetable intake for economic reasons as well, right? The food inflation in fruits and vegetables in particular has been very high. So that's how I've been trying to respond to that reviewer comment, and that's how, I think we're testing more than that, and that's sort of what we're doing.
All right, thank you.
Fantastic. We are at 9, so reluctantly we'll have to stop now. That was a really great session. I like your themes of improving access to food as well as liberalizing. For forever we have been scolding and preaching and telling people to restrict. So this is a wonderful approach, and I really wish you success in your trials. Hopefully, once your research program expands, we can also join in some of your research endeavors. So congratulations and thank you for being here.
Oh, thank you. And yeah, if there are people interested, then reach out, because that 14 center could be 15, right? We don't have a site in Ottawa. So, well, if you see the award for it, then you can send me an email. It's always better to join when there's money.
Absolutely. Thanks again.
All right. Take care. Thank you for the invite.